Um, so welcome to our last session, as she mentioned, and we are going to talk today about basically when you are done with all your analysis, which we have heard like in the last 5 sessions, then we are going to see today how we are going to report the results, actually, how we are going to tell people what we found. So let's go. But before let's start. But before going to that, I want to mention again what are the analysis we spoke about and how we are going to report many of those. So now I see that there were few who were not there in the probably the earlier session. So I hope that you will cover this through the recordings, because the only issue is that today last session was about the outcome of this, how we are going to measure the outcome, and so uh, just catch up with the recording, and if you have any doubt, feel free to get back to me. Now, when we spoke about different economic evaluations, you remember that we talked about one is the cost analysis, where we really did not think about the outcome because we thought it was just the cost comparison. Cost was like the input, or the cost was always in monetary terms in all analysis, whether it is a partial, that is the cost analysis, where we are not considering the outcome. And when we are considering the outcome, then the difference, there are differences in analysis, like the names, how we are presenting our how we are doing, taking into account the outcomes of our work. And based on that, it could be a cost effectiveness analysis, it could be a cost utility analysis, it could be a cost benefit. Just to remind you again, when we will present the outcome of our analysis in terms of, say, hospitalization averted, or number of days of hospitalization, or child death, or anything which is in natural units, those are called the when the outcomes are those in natural units, we call those as cost effectiveness analysis. When we are talking about the long-term thing, when we are thinking about the quality of life of the participants, of our study participants, when we think about, we spoke about DALI, we spoke about QALY, which is quality adjusted life years, disability adjusted life years. So when we consider those, if you remember, DALI, disability adjusted life years, we thought about the life expectancy of the person, right? We that was in the formula. If you think about the quality adjusted life years, which is QALY, we again thought about a long-term feature, like how long the person will be in that state and how will be the utility of that state with the health state. So basically, what does this mean is the long-term effects were considered, and also the utility, the satisfaction, like how long I will be in that state, how I'm giving the ranking of my quality of life during the health state. That was one way. Another way was the disability weight, like how much weight should I put for the health state when I'm in that health state. So those were the DALI and QALY. And when we are doing that, we call it cost utility, because utility, that is the satisfaction of being in the health state, is considered, and it's a long-term measure. So I also spoke about like a short-term outcome, long-term outcome. Short-term outcome can be hospitalization, can be vaccine doses given. I gave an example like that. So those are very short-term outcomes. So you can think of those as your outcome. That is also okay. But if you are thinking of a longer-term thing, that is the DALIs or QALYs. And finally, we also spoke about, if we think of cost benefit, then what will happen is that we have to consider both, that is the input cost, which is always in monetary forms, but then we have to monetize all our outputs also. Whatever the output you are thinking, we have to monetize those in case of cost benefit analysis. So that's the difference. These are the types of analysis we spoke. Now, coming to our cost effectiveness or cost benefit, whatever, like the comparator. So the basic difference between the cost analysis or a partial economic evaluation versus a full economic evaluation is that you are considering the outcome, and also there is always when you are doing a cost effectiveness or cost benefit or cost utility, remember that you have to have a comparator. I told you at the beginning that there should be a comparator. That comparator could be the current scenario, whatever it is. It could be a different scenario. You are comparing between two different scenarios. As I said, that it could be the what we call is counterfactual, that is what is happening now, and and what you want to do. So there are two different things. And in this economic evaluation, you have to compare those. Now, when you have only two options, like you have the counterfactual, what is the current situation, and then you have a new intervention. So then you are comparing between two. But then if you have multiple, let me give you an example. Suppose you were thinking of the example I gave you. I started our discussion 5 sessions before. Like when I started with the example of COVID vaccination, right? So COVID vaccination versus COVID treatment. COVID treatment was the counterfactual that was ongoing, but then the additional thing what the addition you did was the COVID vaccination, and for that you wanted to make sure there will be less hospitalization and less deaths. Your less hospitalization, less number of hospitalizations, you can easily, that's the natural units which you can easily measure, and then measure and put it in the analysis. If you do this is your short-term outcome, and this can be, and the alternatives are, what I'm trying to say here is there are two alternatives. One is that either go with the treatment option or vaccinate, and then think about like lower hospitalization and lower deaths. If you are thinking of lower deaths and you are thinking of Delhi or Kuala, then of course you can understand now that is a longer term outcome, and you can do a cost effectiveness analysis or cost utility analysis, whatever it is, whatever you want to call it. Now, let's think about there are two alternatives where there is one alternative and there are two options where you are comparing. Think about a situation where there are multiple could be multiple interventions. Say, for example, suppose you want to reduce the incidence of diarrheal diseases. Okay, in diarrheal diseases, what the options could be, like you can think of better water quality. For that, you may think of infrastructure development, right? So you can think of better pipeline, giving better filtered water. Those could be one package of your intervention. The second intervention could be that you go to the community and tell the community about mostly the water sanitation hygiene, etc. You talk about those to reduce the incidence of diarrheal diseases. And finally, you can also think of giving a typhoid or cholera vaccine, right? So for reducing the incidence of one like diarrheal disease, maybe cholera vaccine, or cholera incidence, you could have 3 options, right? And when you are doing the cost effectiveness analysis or cost utility analysis, you are comparing between these 3, right? So you have to find out which is your most cost effective intervention. How are you going to define that, which is the most effective intervention for reducing, say, cholera incidence? The option could be like, so you have to find out cost for each of these intervention, you have to find out effect in terms of, as I said, it could be in terms of number of cases averted. It could be in terms of number of deaths averted. It could be, and as you think of death, you may consider about QALY or DALY. So here you are comparing between three options. So how are you going to rank them? And which one would be the most cost effective, and the second best, how are you going to do that? So generally we go, because we always have a budget constraint. I started our discussion with this, that we always have a constraint. And in case of healthcare situation, what we are going to inform is based on the idea that we have our health budget constraint. We cannot just think of doing anything because our budget has limited budget. So given that, we will start with the least expensive option. Out of these three, that is infrastructural development, going to the community to talk about WASH, and then cholera vaccination. I will see which one is the least expensive. And then the second option will be to look at the effects, right? So basically, for each of these, and comparing this with the current situation, that is like how, say, for example, cholera or diarrheal cases, whatever is your option, that's up to you what you are doing. For that, whatever the current situation is, how the current situation is running. And that's where, if you remember, that we talked about the incremental cost, because it's not the full cost, it's the incremental cost, because the additional, whenever you are doing an infrastructural development, say for diarrheal diseases, there is a pipeline, right? There are some water supply already, but what you are trying to do is to do it in a better way. Or where there is no supply, you are installing maybe new pipelines, or you are installing some water filtration process, or whatever. I'm just giving you the examples. So those are the additions. It's not that there is just nothing. There could be nothing. In cases there could be nothing and you are doing everything new. That is also okay. But what I'm trying to say, everything you are doing is incremental. And when you are not doing this, I spoke already about this several times, that whenever you are doing something new, you are expecting something different. When you are not doing, there were few number of diarrheal or cholera cases. When you are doing this, there would be a reduction or increase in cases. You never know. It could be an increase of cases as well, or it could be a decrease of cases as well. So basically, at the end of the day, you are comparing the incremental cost and incremental effectiveness, additional. So the formula, the incremental cost effectiveness ratio, this is the last thing you are going to report in terms of ISR, incremental cost effectiveness ratio. What is the formula for that? Is the simple formula, even if you have multiple, so you have this comparison, right? You have cost O minus cost N. What is cost O? Is the old intervention. Old intervention does not mean that there is an intervention. It could be the, as I said, the current situation with which you are comparing. And then effect O minus effect N. Previously, there was some effect. Now there are some effect. What is the difference? It could be negative also. As you can see, cost could be higher. Your ISR could be negative. Effect could be lower. Your ISR could be negative. But then the question, what I'm trying to say is, your analysis will be cost difference divided by effect difference, the incremental cost divided by incremental effect, which is the ISR. That's what you are going to report at the end of the day. Now let's see what are the complications arise. When you have those options, if I put those options in a graph, you have three different options in my example of diarrhea or cholera. So what could happen, 0, 0, as you can see in the middle, is the, so I have a space where I have a horizontal axis, I have a vertical axis. The horizontal axis is telling me about the health lost or health gained. Towards the right is towards the right of 0, 0 is the health gain. If that's the positive health, that is your intervention as compared to the comparator. The health is improved if you do this new intervention. If you are on the left of 0, 0, that means that if you are doing a new intervention, actually it is giving you less effectiveness. Okay, a new intervention as compared to the previous one, the one with which you are comparing, is giving you a lesser health outcome. The vertical line is telling me the cost difference. Below 0, 0 is less costly. It's minus. So it's like meaning as compared to the comparator, it is lower. If I go up, it meaning that above 0, 0, it means that it is more costly. So whenever you have your 3, 4, whatever number of interventions, and you find the cost of the intervention and the cost of each of this intervention and effect of each of this intervention. Now you can put anywhere here, right? So you can put cost versus effectiveness in this graph. And in this graph, if you can imagine that you can have all these 4 options. It can be that the new intervention is more costly but more effective. It can be that the new intervention is less costly but more effective. It can be it is less costly, less effective. It can be more costly, less effective, right? You can think, you just think about it, that you will have all these 4 options. You can have either of these options for each of your intervention, whatever is the number of interventions you have. Now, so A, B, C, D are my 4 options where anywhere my intervention, the new intervention can lie. Can you tell me where in these 4 blocks my intervention will, where in this space my intervention, if it is there, then I will definitely choose. Which of this region, if my intervention falls in that region, then I will definitely go for it. Or not I, the policymakers will definitely go for it. Which is the region? I want to, okay. In the chat, please, which is the region where if my intervention is there, falls in that region, I will definitely go there. I will not think anything. I will just say, no, you have to accept this. Which is the region? Okay. I got 5 answers. Why not more? I am repeating my question and I want an answer. Suppose my intervention, as I say, as compared to the comparator, I find that my intervention can be in either of this region, A, B, C, D. There are 4 regions, and I explained that what that the region means. When you are towards the right on the horizontal axis, it means that health gain. That means that intervention has a better effectiveness. If you are up from 0 to 0, it means that it is more costly at compared to your comparator. If it is down 0, 0, below 0, 0 on the vertical axis, it means that it is less costly. If it is on the left side of the 0, 0, it means that even if you did the new intervention, but it has a lower effectiveness. Now, my question is, suppose in which region, if my intervention falls in all of these like 4 regions, where do I choose my intervention immediately if it is in that region without thinking anything? Which is this region? Okay, I will not wait further. I got the answer from many of you, and that's A. That's the right answer. Because A is no doubt that is the best option, that it is the new intervention is less costly and more effective. So as compared to my comparator, I see that, oh, it's less costly and more effective. That means I should definitely go for it. I don't need to think about anything. I should recommend that, oh, this intervention is going to really work. So that's good. So if I am at A, I would definitely go. Now tell me in which region I would never go. If my intervention falls in one of those regions where it is, where I will never choose this, which is that region, which should never be chosen. Okay. So I'm asking which is the region if my intervention falls, I will never choose this. When I'm saying I, actually is the government, right? Because the policymakers or whoever you are giving your report, when you are suggesting or the policymaker decides that no, this cannot be chosen. Which one is this? Okay, I will not wait much. I got some answers and absolutely right is C. It's because it is more costly and less effective. So there is no way that we should choose that because it's not giving me good effectiveness and as well as it is more costly. Now tell me what to do if I am at D or B. Am I going to choose those or what? What is your decision? Am I going to choose D? If my intervention falls here, it is less costly, but at the same time less effective. Am I going to choose D? What is the policy makers or the decision makers decision will be if I am in D, my intervention falls in D. Any idea what I'm going to do? When you say no, my question will be why not? Because it's less costly. It's less costly because I'm okay. Yeah. But see, our major concern is our budget constraint, huh? So, um, yeah, because our major concern is budget constraint. So less costly intervention, we may think of it, but see, we are hesitant because you are not also answering. You are also thinking like, should we go for it? Because less costly, but at the same time less effective. On the other hand, if you think of B, which is more costly, but at the same time more effective. So what to do? So these are the two areas where whether to choose or not depends on a threshold, which is called cost effectiveness threshold or search for effectiveness. We already know the effectiveness, right? So basically, this is the reporting, as I say. We already know the effectiveness. We already know the cost of our intervention versus the comparator. And that is what we are putting in this space. Like when we create a graph, my point is that my intervention can be in either of this region, right? Now you all agreed that if the effectiveness and cost wise, if my intervention is found to be less costly, more effective, you all said that I should definitely go for it. That is, if my intervention falls in the area of A, definitely yes. More costly, less effective? No. It's a big no. In C. But the confusion started when I'm finding that my intervention is less costly, but at the same time less effective. Or it is more costly than the comparator, but it is more effective as well. These are the confusing system, like situation, huh? And in this situation, what we do is to say whether my intervention, even if it is in D or even if it is in B, whether I will go for it or not, it is dependent on the cost effectiveness threshold. I'm sure those of you who have heard about it, read a little bit of economic evaluation or did those, you know that there is a term called cost effectiveness threshold or willingness to pay threshold. So I'll come to that. So these, as you understood, that B and D are the situation where we have to take a decision based on something, and that something is the threshold. Let's go. So suppose in B, sorry, let's think about D. Let's look at, sorry, D again. Less costly, less effective. Now let me explain this. Less costly meaning what? This is just an example, okay? I'm just trying to tell you what happened, how we are going to choose. Suppose the old intervention was costing me $100. The new intervention is costing me $90. That means it's less costly. Old intervention effect is 100 deaths, but new intervention is actually more deaths, 5 more deaths. But here the situation is that I saved $10, right? So this is called disinvestment. That is, previously I was investing 100, but now I am investing 90. So I have disinvestment. So I have actually free $10. Now, this $10, I will not keep this idle, right? I will put it somewhere in the health system. Suppose I put this $10 somewhere in the health system. I don't know where, anywhere in the health system. And then when I look at the overall situation, overall picture, health outcome, I see that the deaths reduced to 90. So what happened then? My $10 disinvestment in this intervention have overall effect, better effect, right? Because even the old intervention was giving me 100 deaths, but now I'm getting like 90 deaths. That means deaths reduced. Even if I'm giving less money in that intervention, but I freed up my resources and I put it somewhere else, which actually meant my overall health situation much better, which is 100 deaths to 90 deaths. So this is where I really have to think about it, because see, overall the situation is much better. But as you can understand that it is extremely difficult to figure out where the money will be put and how will be the outcome measured, etc. So that's where again this is just an example to make you understand what I mean. But then when I use this $10, I actually make a overall better health, which then whether to take this investment or not, or the intervention or not, that will be decided by the threshold. This is what is. So again, I'm giving you this table because this is exactly what it is saying. If the cost increases, effectiveness decreases, never do. If the cost increases, effectiveness increases, cost increases, effectiveness increases is your B, if you remember. Cost decreases, effectiveness decreases is D. And cost decreases, effectiveness increases is your A. So you already answered those, but whether this will be cost effective or not, these two situations depends on the threshold. I have another question for you. Look at this graph. This is PCV, which is pneumococcal vaccine for children. And this is a study from Hong Kong. They did a cost effectiveness analysis and they are putting these two diamonds here. The horizontal axis is telling you the qualigand. So as we move towards the right, as I told you in our situation also, like if you remember the graph, so it is the qualigand is positive, it is increasing, and the cost is increasing. Now, you have two options. PCB10 is here. This is cost and quali. This is the cost item on the vertical axis. On the horizontal is quali. So you have cost per quali here, and you have cost per quali here for PCB13 and PCB10. Which one you will select? Answer in the chat. Which one are you going to select? PCB10 or PCB13? I hope you understood the graph. The horizontal axis is telling you the quality gained. That is towards the right, it means the quality gained, and up is higher cost. Which one are you going to choose? Okay, good. So it's PCB10 because PCB10 has lower cost, higher quality gain. Very, very clear, right? Even if here, generally when a new variant of vaccine, 13 meaning that it has more variant, even if it is more variants are coming, it clearly shows that it is more costly, but it is not, in terms of quality gain, it is not that great. So definitely we'd go for PCB10. Okay, so this type of analysis will tell you this information. Now, the threshold. As I mentioned that we have to select a threshold to decide whether I am going to choose that intervention when I'm in total dilemma in D and B. Now, this threshold, what does this threshold mean? There are a demand side concept, there is a supply side concept. The demand side concept tells us that we, as the consumer, we have a preference for our health, right? So we can say something like we can tell how much we are going to pay for getting this health benefit. Say, for example, you are asking people to tell us that how much money are you willing to pay for a cholera vaccine, for example. And then to another group, you are asking how much money you are going to pay for HPV, that is cervical cancer vaccine. Do you think the willingness to pay will be similar? No, right? It would be different, and it would depend on several other things. So basically, meaning that those who are not at risk of having cholera or HPV, they would definitely say a different willingness to pay for the vaccines, right? So basically, that willingness to pay threshold is from a consumer point of view, like how much I'm willing to pay for a particular health gain or avoiding that health loss, whichever way you look at. So that's one way. That's the demand side, what I am demanding, what I'm ready to give. The supply side is again the budget constraint which we started with, because the government, for everything, they have a fixed budget. They will be very happy if it is less costly, but they cannot go beyond that, right? When they will go beyond that is when we are thinking of that willingness to pay threshold, or is the threshold. Now, if you want to know what is the willingness to pay threshold for the Indian population, it will be extremely difficult to calculate, right? You can imagine that it requires so much of information, because there are so many, like health meaning it's so many things to consider, right? So it is extremely difficult to calculate that. For one vaccine or one intervention, you can always ask people, and that is a smaller willingness to pay study. That can be. But for a decision maker, it's not a small, I mean, it has to has a well-defined threshold through like with which you are actually comparing, right? So therefore there has to be a well accepted threshold, and that threshold is which is most commonly used, most commonly in almost all economic evaluations, you will see that this is used, which is WHO choice. WHO choice is choosing the most effective interventions. That there was a study by WHO, and there are a lot of information there. In WHO choice, they have given this, that my willingness to pay, any person's, not mine, anyone, from a consumer point of view, their willingness to pay will not go beyond the gross domestic product of that person. I mean, when I'm saying a consumer, then I'm saying the gross domestic product of that person. But when you are thinking of a country like Indonesia, India, Bangladesh, think about everyone. So how I will know what is the GDP or gross domestic product per capita? So that definitely you have to use the country's GDP per capita. There is no other way. So that is the WHO recommendation, that the threshold, if your ISR, incremental cost effectiveness ratio, is within GDP per capita to 3 times GDP per capita. If it is within that, so let me give you again an example. India's per capita income last year, 2023, was about $3,000. Okay. So if any of your intervention is $3,000 to $9,000. Why 9,000? Because 3 times GDP per capita. $9,000. If it falls between $3,000 to $9,000, you are good. It's cost effective. That's the threshold. Okay. If it is below $3,000, that means it's very cost effective. That is, it is even below GDP per capita. So it's very, very cost effective. Okay. So when you are in doubt, like in B or D, you compare your ISR. ISR is the incremental cost, incremental benefit. You compare your ISR with the country's GDP per capita. Now, if you ask me what is GDP, very briefly, GDP is the country's gross domestic product, meaning whatever the country produces from different production units is the total of the country's GDP. It is divided by the total population of the country to get GDP per capita. This is a very, very common economic term, which is GDP per capita, and the WHO recommends that GDP per capita, that means that's the capacity of one person. What they mean is, because that's the gross domestic product of the country divided by the whole population. It's not working population, all population. So that means that GDP per capita can be the threshold. If my intervention is below that, it's very cost effective. If it is within the GDP per capita and 3 times GDP per capita, you can say that it is cost effective. Not very, but cost effective. It would be very cost effective if it is below the GDP per capita. So that's the threshold. I hope you understood. If there is any question, please feel free to write in the chat. So Bangladesh will also have a GDP per capita. And remember to use the GDP per capita during the time you are doing the analysis. And always, I forgot if I mentioned this or not. When you do any intervention, if you are doing along with the intervention, then it's fine. But at the time of analysis, you will be reporting. I will come to that when I talk about the reporting. When you will be reporting for a particular year, right? So always try to report the last finished financial year. When I say last completed financial year, I mean it's not 2024, because 2024 is not finished yet, right? So it's still ongoing. You should not, if you are doing a calculation now and you are going to report your results now, you should not be reporting in 2024 prices, because 2024 is not complete yet. So it has to be 2023. So if you remember, if you just notice that I talked about GDP per capita in India in 2023, why? I could have said that 2024 value also, whatever is available now, but no, we are not completed yet. The year is not completed. So it's 2023 GDP per capita. India was 3023 or something. So if an intervention is below my ISR, incremental cost effectiveness ratio, if it falls below $3,000, it is very cost effective. If it falls between $3,000 to $9,000, it is cost effective. That's the simple thing which you can do using WHO recommendation. And the most common thing, as I say, people do only this. But then several countries like England, Thailand, USA, they tried to calculate. The problem is that GDP per capita, of course, not always the correct thing to report, right? And so there are countries who actually try to estimate the threshold. Thailand, England, USA are the countries where threshold was calculated. And you can see the difference. They calculated 2,400, like 2,40,000 baht per quali is their threshold estimated. But when they use their GDP per capita, it was 160,000. So you can see the difference. You can see the difference everywhere, estimated versus the explicit threshold. So that's why it is good to have a country specific, but only these three. And there was an attempt by one of my colleagues in South Africa. She tried to do it for South Africa. So I mean, there are only a few countries who have this. For us, we have to use the WHO threshold. Any study. Okay, if there is any question, please feel free to ask, because I'm going to now talk about the reporting. You have done with your work and you are going to report this. It could be in terms of a report, it could be in terms of a publication, anything. When you are going to report your study results, you have to maintain the quality. And the quality of analysis, there is a checklist. So as soon as you try to report it in a good journal, they will look at it, whether you have all this information required for reporting your result. This is called CHEERS, which is Consolidated Health Economic Evaluation Reporting Standards. You have to go through this CHEERS checklist, and you have to ensure that each of the checklist items are ticked and properly placed in your report or paper. And that ensures that you have considered everything. Okay, and this checklist should not only be used for cost effectiveness, cost benefit, cost utility. It should also be used for a cost analysis. Ideally, it should be. There will be several questions which will be not applicable. Write down not applicable, because the outcomes, etc., will not be applicable for cost analysis, right? So you write down that it is not applicable, not applicable. If you're not doing a modeling, say for example, you are just thinking about doing your outcome is hospitalization averted, number of vaccine doses given, number, or like the measurable units, then you are not doing any modeling. Like when I say modeling, is meaning decision tree or Markov. We talked about it, right? You remember. So when you are not doing those kind of modeling, some of these questions in the chair's checklist will not be applicable. So write down not applicable, but still you have to ensure that you maintain, you have the whole list, you considered, and then you tick that, and you have to mention where it is. So let's talk about this, because it's the quality of your work. What are you going to report in the checklist? What are the items it should be? So that you need to have a title, and every time they have a guidance also, how you are going to report those, okay? And at the end, you have to mention, so you actually have to give the checklist as an annex or something, as a supplementary material, so that the reviewers can check how well you did the analysis. And you have to mention where in your write-up, where did you mention this. So the last column, as you can see, is talking about the reported in section where it was mentioned, okay? So basically you have to have a good title, you have to have an abstract, then in the introduction you have to have a background and objectives. But if you look at the method section, you will see that whatever we spoke throughout these 6 sessions, you have everything. You need to mention all of this, like what is your analysis plan. If you did not do an analysis plan, you can say not applicable. But starting from study population, definitely you have to have a study population, setting and location. What are the comparators? I'm telling you several times that you have to have a comparator. So you have to be very clear that what are the interventions and strategies you are comparing and why. Why you chose that versus that. Perspective. I have told you several times that that determines so many things, that what cost, how are you going to do it, time horizon, how long are you going to think about it? Like, are you going for a longer term? Are you going to think about the daily quality sector like a longer term? Or why are you thinking of a intermediate, like a shorter term outcome, and why? Then discount rate. When you are going for a longer term, we spoke about it, like you have to discount. That is, you have to take the future value into current value. We spoke about those. So discount rate. Then your selection of outcome. How are you going to select those? How are you going to measure those? Like what we spoke last session, like how we are going to measure, how we are going to value. If you remember, we talked about EQ5D. We learned about how to do daily calculation, how to do quali, all these valuation of outcomes, and how are going to do, you have to write down. Then how are you going to measure the cost? What are the currency? What are the conversion rate you are using? And then price and date. As I said, which year are you doing the analysis? Okay. Then description of the model, whether it is a decision tree or Markov, or why did you think about doing a decision tree or Markov? Why not other things? Any analysis, any heterogeneity, like why, if you are doing this for different subgroups, why did you choose those subgroups? Why? Or heterogeneity could be if you are doing in different population. Say, for example, you are doing it for 3 different countries, like the countries which are attending to this session, like country Bangladesh, Indonesia, and India. You are doing it, so it has heterogeneous result, right? So explain those. Why are these? Why did you think about this? Then coming to another thing is the uncertainty. Because when you were thinking, say for example, I told you when I was talking about discount rate, I said that the generally accepted discount rate is 3%. But then you will also see that I told you that the central bank deposit rate is also taken. And I said that in our studies, we generally use the central bank rate, which is around 6%. So you can do an uncertainty analysis, which is called sensitivity analysis. And all of your analysis should have this sensitivity, meaning some of the assumptions, if you vary those assumptions, it will have impact on your results. Think about those components, those, what should I say, inputs in your model, which can influence your result. Do another analysis, which is called the sensitivity analysis. You can do one way, or you can do univariate, or you can do multivariate, but that's a different story. But what I'm trying to say is, based on your inputs, which can influence the results, you can vary those inputs and see how the results are changing. And that's your uncertainty analysis. And you have to mention that in the method section, what are you going to, which of the inputs you think will have a different effect if you change those, and you have to mention those in the method section. So I hope you notice that how big is the method section. It's a whole lot of things which we touched upon is you have to mention. Then the results, you have to mention the main result, the summary result, and then you have to give, if you are giving the mean, you should give the standard deviation. If you are given the median, interquartile range, something like that, you have to. So those are then there will be a discussion where you talk about the study findings, limitation, generalizability, etc. Other important factors which will come is source of funding, conflict of interest, etc. Also, you need to report. So I will be sharing with you this checklist, and you have to ensure that when you do this kind of analysis, you have to ensure that you follow this checklist. Whichever is not applicable, which you are not doing, you say that this was not done, but you have to mention this. Okay, so I have a quiz for you. Which of these is not there? You don't need to report in Cheers checklist. Which of these you don't need to report in Cheers checklist? In the chat, please. Which of these you don't need to report in Cheers checklist? Think about it. Which is not required? Why all of you are silent? I got only 2 answers. Which of this is not required in checklist? Okay. I got 1, 2, 3, 4, 5, 6, 7, 1, 2, 3, 5, 6, 7, 8, 8. Okay, 8 answers. Okay, so some of you said E and a couple of you said B. B is not the correct answer. You definitely need to say which currency you are talking, currency you are presenting your result. You definitely, because I told you, right, like which year you were doing your work. So if it is 2023, that means you are using 2023 prices. You have to mention that. That's absolute requirement. So that's not, so come back to this here. Here, currency, price, date, and conversion. Definitely, this is a requirement. You have to mention this. Here, what is not there is the author's affiliation. You really don't need to say that. Who the reporting, the study is judged based on how you did the study, not by the author or the author's affiliation, right? So that's not a requirement. The requirement is that how good you have done the study, you have reported your methods, how good you are in the methods, you in the analysis, in the discussion, etc. It does not require your affiliation, the author's affiliation, as the as one of the major items in the checklist. So those who answered E is the right answer, but B is not the correct answer. B is absolute. All these rest, all of these A, B, C, D are the absolute requirement for that year's checklist. Okay, so that's the end of our economic evaluation course.